So good morning. My name is Sudha. I'm one of the third-year cardiology fellows at the University of Cincinnati. So I'll be talking to you about a complication on VA ECMO, but I'd like to ask your opinion if you think it's a complication or a red herring. So the objectives: recognizing the development of cardiac tamponade and its management on VA ECMO, and understanding the unique hemodynamic profiles of VA ECMO. So we'll start off with a case of a 42-year-old male that presented to our institution, no significant past medical history, developed acute onset substernal chest pain radiating to his left shoulder with associated nausea while at a local amusement park right after riding a roller coaster. EMS showed anterior STEMI, and he arrived actually at one of our neighboring hospitals. So he was given aspirin and sublingual nitro en route. He was noted to be diaphoretic, hypotensive. He was loaded with Brilinta and given a heparin bolus prior to being considered for the cath lab. Developed unstable VT prior to transfer to the cath lab, failed cardioversion, given amio, and started on an epi drip. He arrested again on the cath table, VT arrest, PEA arrest several times. And finally, ROSC was obtained after 2 boluses of epi, atropine, and several rounds of CPR. So left and right femoral arterial sheath was placed, and the right was eventually upgraded to a 14 French for an impella. The left femoral venous sheath was placed for a PA catheter. And this is his angiogram. Let's see. Yeah, it was bad. The impella, and then you saw wires down the coronaries as well. So right after revascularization, he actually had good pulsatilities, blood pressure of 110, and this is on norepi and epi. He was also started on inotropes, IV dobutamine, and that's just some of his diagnostic data. He was obviously acidotic, lactate was elevated. His troponin was probably the highest I've ever seen. Eventually in his hospital course, he was in the hundreds. And his CVP was 11, his mean PA 28, his index was 1.9 with the impella at P8 setting. So 6 hours after his presentation, he was cannulated for VA ECMO. The impella was removed and exchanged for a 21 French arterial cannula via the right femoral artery. A 23 French venous catheter was left, cannula was left in place, and subsequently he developed a large right groin hematoma. Obviously he was continued on his anticoagulation. So on ECMO, I've highlighted in red, his RA pressure was 20, his mean PA is 45, wedge was 35. You can see that he's starting to develop congestion on his x-ray. And we continue to have issues in decompressing his LV. He obviously developed worsening pulmonary edema, not responsive to diuretics, and developed renal failure and finally progressed to CRT. So on his hospital day 2, overnight events is when he really decompensated. And he became more hypotensive, developed a refractory vasoplegia. And so he was on epi, levo, vasopressin, dobutamine, and methylene blue. So we kind of, ran through everything in our heads, got an urgent bedside echo that showed a large pericardial effusion with RV collapse, and so he had findings consistent with tamponade physiology. So his bedside pericardiocentesis was performed, and drained about 250 cc's of serosanguinous fluid, and so the fluid studies were consistent with the transudative effusion. This is just a graphic trend to kind of depict how he progressed, or how his labs and other data progressed during his hospital stay. So on hospital day 2 is when his lactate was the highest at 14. I don't have the troponin on this because it threw off my graph, but he was like well into the hundreds. And his wedge and CVP were all elevated. But the biggest finding here is that his hemoglobin was down by half. He came in with a hemoglobin of 16 and it was down to 8. So unfortunately, he ended up developing intracranial hemorrhage and progressive multi-organ failure and VA ECMO was terminated, and he expired on hospital day 4. So what happened? We know about complications on VA ECMO, bleeding and coagulopathy, about 5 to 79%, limb ischemia, like the previous speakers spoke about. So he developed this refractory vasoplegia, and he had this rising lactate, troponin, and anemia. He was given blood products, several blood products, but there's the possibility that we just didn't keep up with his losses. And so he started going downhill on VA ECMO, and I think there were several things that we should have thought about in terms of, not being able to keep up with his losses. He might have developed this tamponade physiology for that reason, because he was underfilled. The pump itself also, we know that VA ECMO increases after load, causing LV dilatation, myocardial ischemia, elevated pulmonary pressures, blood stasis, and potential thrombus formation. So what was exactly the inciting factor? Was it a multitude and combination of everything that led to his downfall? And we know about acquired von Willebrand syndrome. This was touched upon on the prior days, and this is just a small study, 18 patients, that showed that collagen binding capacity was decreased right after ECMO implantation and actually reversed after explant. Hemorrhage on ECMO, just several studies depicting various ways patients can have bleeding on ECMO. And also venting on ECMO, and I think one thing that I'm going to take home with me is the importance of LV venting on ECMO patients, and actually just patient-specific, ones that would benefit from it. That's it.
So, very excellent case. So one question would be exactly that, is that usually if you have an impellin that's functioning, and as Ali had said, you have the luxury of another spot, probably good to keep it. The second question related to that, though, is the groin hematoma. Sometimes when patients are going downhill and there's that much blood loss, 250 cc's is not 10 units of blood. Maybe you had a retroperitoneal bleed. It's one of the things that's the enemy of VA ECMOs. You can't flow because you just have, the retroperitoneum is like an endless pit that you can put blood into. So I wonder if that hematoma in the groin was anything larger than what you described.
He was just too unstable, but yes, that's definitely a possibility. So we didn't scan him or anything at that time, but.
Questions? Ali, question? You've never been given the floor, so I thought perhaps you can have a final comment. But yes, well, anyway. Having said that, thank you for your presentation. I think we actually made it to end up on time. Thank you for your presentation.